We're going to look at the urinary system, and we're going to start off with looking at the urinary anatomy. And so we're going to revisit the core principles of structures with their function. We're going to look at gradients, feedback loops, and cell communication. We're going to be able to describe the location and external support of the kidney. We're also going to list and describe the organs of the urinary system, which is going to include the microanatomy, and the blood vessels that supply the organs, mainly the kidney. We're going to describe the major functions of the kidneys, and we're going to be able to trace the pathway that the filtrate has to follow in order to become urine. We're going to look at the difference, or we're going to compare and contrast cortical versus juxtamedullary nephrons. And we're also going to look at something called the juxtaglomerular apparatus, and we're going to talk about we're going to start talking about what these cells do in order to maintain homeostasis in the system. We're also going to look at the development of the urinary system. So the urinary system is going to be comprised of a pair of kidneys and the urinary tract, where the kidneys are going to filter blood and remove any metabolical waste. And in addition to metabolical waste, we're going to remove harmful substances. And you're also going to see the modification of fluid through the maintenance of fluid and electrolytes homeostasis. In addition to that, the kidneys are going to be important for maintaining acid-base balance and blood pressure homeostasis. And when we talk about the urinary tract, we're going to say that the urinary tract are going to be other organs outside of the kidneys, which will be the ureter, which is paired, the urinary bladder, and a single urethra. And of course, urine is going to exit the kidneys through the urethra, which is located on the posterior body wall. And each ureter is going to empty into the urinary bladder on the floor of the pelvic cavity, where urine is going to be stored. And of course, urine exits the body from the urinary bladder through the urethra. And of course, the urethra is what allows urine to exit the body. So we're going to look at the gross and microscopic anatomy of the kidney. So when you look at the kidney looks like two bean-like structures. And of course, they're also going to be the color of what we know as kidney beans, which is a reddish brownish color. Of course, both kidneys are outside of and posterior to the peritoneal cavity. So these organs are retroperitoneal, the same as the pancreas. When you compare the right to the left kidney, you would notice that the right kidney is going to be slightly inferior to that of the left kidney, because the liver, which sits primarily on the right side, will displace that right kidney. The left kidney is positioned between the T12 vertebrae and of course the L3 vertebrae, and of course the 11th and 12th rib will provide protection for both kidney. Of course, you look at the kidneys, you have the adrenal glands that sit on the top portion of the kidney. Of course, the adrenal glands are part of the endocrine system, and they're not a part of the urinary system. So they're a whole different organ from the kidney itself. When you look at the kidney, since it's retroperitoneal, it's going to be supported by these three different connective tissues. And these three different connective tissue is going to be the fibrous capsule. And so the fibrous capsule is going to be the covering of the exterior portion of each kidney. And this is going to have projections of collagen fibers that's going to go from the perinephric fat into the renal fascia. And this is a thin layer of dense irregular connective tissue, and it's going to protect the kidney from infections and physical trauma. Next, you have the paranephric fat right here. And the paranephric fat is a thick layer of adipose tissue, and it's actually the thickest of the three layers. And it's going to wedge each kidney in place. And this is going to shield the kidney from any kind of physical shock. And then on the outermost part, you have the renal fascia. And the renal fascia is going to anchor the kidneys to the surrounding areas. And so when you look at clinical homeostatic imbalances in reference to this, upper parts of the kidneys are protected, but you also have the fat that cushions the kidney. However, the lower part of the kidney is more susceptible to blunt trauma, especially the right kidney, because it sits extremely lower than, well, not extremely, but slightly lower than the left. And of course, if you have falls, any kind of motor vehicle accidents, or any kind of contact sports, you're more likely to damage the right kidney or the kidneys as a whole. The right renal artery is also vulnerable to injury from rapid deceleration during car crashes. And of course, you have lacerations or thrombosis that can occur with this artery. You can have hematuria, which is blood in the urine, which is a major sign of some kind of trauma. And of course, you need surgery to treat this. And so essentially, the kidneys are, though some of it is covered by the thoracic cavity and you have fat, they're very susceptible. And you'll hear about kidney blows when you look at boxing tournaments or any kind of fighting matches. And that's a legal blow because you can damage the kidney. So take a look at the main structure of the kidney. Of course, we have the fibrous capsule, as we described previously, which is the outer covering that that is going to be continuous, which what is known as the renal sinus. But when you cut open the kidney, you'll notice that you have a renal cortex and a renal medulla. So the cortex is the superficial region of the kidney, and it makes up about 90 to 95% of all kidneys blood vessels. So when you look at after the renal artery comes into the kidney and it divides, most of the blood vessels will be located in this cortical region. The renal medulla is the inner region of the kidney. It consists of the renal pyramids, which is, as you can see, a conical shaped structure. And in the renal pyramids, you have renal papillae that is going to be at the tip of the pyramids itself. And then you have the renal columns that are going to separate the adjacent pyramids. And the renal column is, in some textbooks, will say it's a part of the cortex because it has a similar color to the cortex, while others will include it with the medulla because it's in the region of the medulla. So if you read one thing versus the other, it's fine. Of course, if you were going to look at a kidney lobe, which is the pyramid, is the overlying cortex. So when you look at here's your kidney lobe. So it's the pyramid and the cortical region that is associated with it. And of course, each kidney contains about 6 to 18 of these lobes. You do have other features such as the hilum, which is the medial indentation of the kidney. And this is a point of entry for the renal arteries, the renal nerves, the renal veins, and of course the ureter right here. You also have the renal sinus, and the renal sinus is going to be a cavity that is lined by the renal capsule itself, which you'll see that you have the opening for the hilum that is going to come into it. When you look at the sinus, it's going to be where you find the structures that's going to drain the major aspects of the kidney of the urine. You also have fat. So a lot of adipose tissue is going to be located within the renal sinus. And of course, in the renal sinus, you'll find the location of the minor calyxes, which will collect urine from a single lobe. So here's a minor calyx. And so the major calyx is going to collect urine from multiple minor calyxes. So this will be the area of the major calyx. And then multiple major calyx will collect into the renal pelvis, which is a funnel-shaped structure. And of course, this renal pelvis is continuous with the ureter. So when you look at the kidney, the functional unit of the kidney is the nephron, and there's over 1 million nephrons, which are filtering apparatus that are within the cortex and the medulla of each kidney. So it's not located in one region versus the other. It's actually located in both. And we'll talk as we go along. You'll see what parts of the nephrons are located in which parts of the kidneys. And of course, when you look at it, it's going to consist of a globe-shaped renal corpuscle. You're going to see long renal tubules. And in this picture, you really don't see it, but there is an associated blood supply. So that's what makes up the nephron. Of course, you have two different types of nephrons, which would be cortical nephrons and juxtamedullary nephrons, where the cortical nephrons make up about 85% of all nephrons, and they're going to be located in this cortical region, where you have juxtamedullary nephrons, which are also located in the cortex, but they're going to be located closer to the renal medulla. And they make up about 10 to 15% of all nephrons. And the distinguishing part, other than location, is that juxtamedullary nephrons have very long nephron loops that permeate or go deep into the medulla. And these nephrons are very critical for producing concentrated urine, whereas the cortical nephrons are responsible for most of the regulatory functions of the kidney. Of course, these nephrons are going to filter out approximately 180 liters of fluid daily, but most of this fluid will be returned minus the waste and the harmful substances that are going to actually be excreted through the urine. And so we're going to now look closely at the microanatomy of the kidney, which is the nephron and the collecting systems. So the renal corpuscle is that globe-like structure which is responsible for filtering the blood. It is composed of two parts. You have the glomerulus, which is a group of lupin fenestrated capillaries, which, as we remember, fenestrated capillaries are extremely leaky. They're not as leaky as sinusoidal capillaries, but they're fenestrated capillaries. And we know that fenestrated capillaries are important for filtration and absorption. And we have the glomerular capsule, which is also known as the Bowman's capsule, which is a double layer outer sheath of epithelial tissue. And we have a outer layer and an outer parietal layer and an inner visceral layer. So let's take a closer look at this. So here you have the globe-shaped structure, which is your renal corpuscle, or your Bowman's capsule with the glomerulus. And so again, this is a globe-like structure which consists of a parietal layer, and this parietal layer is actually an extension of the proximal tubules, but this is a simple squamous epithelium. The visceral layer is going to be made up of modified epithelial cells called podocytes. And so here are the podocytes right here. And these podocytes are going to have foot processes or pedicels that are going to surround the glomerular capillaries, and they're going to form what is known as filtration slits. And of course, you have the capsular space, which is a hollow region between the parietal layer and this visceral layer that is going to, again, be continuous with the entrance of the renal tubule lumen. Okay. And so also, if you were to do a cross section of the glomerulus, which includes the podocytes and the glomerular capillary, you'll also find these cells called mesangial cells. And these mesangial cells are supporting cells that's going to lie between adjacent glomerular capillaries, and they're going to essentially control the capillary's diameter and the rate of the blood flow. So now we're going to talk about the renal tubules, which is everything away from the renal corpuscle. And so they're going to be modified structure, and they're going to have very functional distinctions between these different regions. And so you have the proximal tubule, also known as the proximal convoluted tubule. You have the nephron loop, which is also known as the loop of Henle. Then you have the distal tubule or the distal convoluted tubule. And then you have the collecting system, which will consist of the collecting ducts and the papillary ducts, which are also functionally and structurally distinct. So let's start talking about the proximal convoluted tubules or the proximal tubules. They're the first and the longest segments of the renal tubules. Of course, they have both straight and coiled sections. And when you look at the cells that make up the tubules, they're made up of a simple cuboidal epithelium that have prominent microvilli. And of course, these microvilli projections are going to face into the tubule lumen to form a brush border, which will increase surface area for this region. And if you look here at this chart, you'll see these orange arrows, which are going to be associated with reabsorption or secretion. So that lets you know that this increased surface area is going to be important for maximum reabsorption. So then we're going to look at the nephron loop, which is also known as the loop of Henle, which is the next segment that the filtrate enters, and only part of the renal tubule will dip into the medulla. So this is the only part that actually extends into the renal medulla. You have a descending limb, which goes down, and an ascending limb, which comes up. The descending limb is known as the thin descending limb because it's made up of mostly a thin tubule. It does have a thick region, but most of it, as you can see, is going to be a thin limb. And of course, this is going to be a simple squamous epithelium that is, of course, going to make a 180-degree turn to form the ascending limb. And of course, mainly the ascending limb is going to be thick and is going to be made up of a cuboidal epithelium. You do have a specific region of the ascending limb that is going to be a thin tubule, which is again going to be a simple squamous epithelium. Lastly, when the ascending limb gets back to the cortex, it is going to be called the distal convoluted tubule or the distal tubule. And of course, it will also have straight areas and convoluted areas, just like the proximal convoluted tubules. But you'll see that this is going to be composed of a cuboidal epithelium that lacks a brush border. So you can tell that not much reabsorption is going to occur here. And of course, you can see by these arrows. The next thing we're going to talk about is the collecting system, which is a series of functional and structural distinct tubules that's going to consist of the collecting ducts. And of course, you have the papillary ducts that's going to be in the medulla. And of course, these are going to be modified. They're going to also mainly allow for filtrate to pass. And this is going to be dependent on specific signals. So, of course, you have several distal tubules that will empty into a collecting duct, when the collecting ducts are primarily in the renal cortex. And then the cortical collecting ducts will form a medullary collecting duct that is going to primarily be in the renal medulla. And of course, when you look at the cells, you're going to have intercalated cells and principal cells that make up this collecting duct. And of course, these cells are going to be very important for the function of the collecting ducts, okay? And they're going to be involved with regulating of urine output. So they're going to be responsive to aldosterone and angiotensin. And then you have the collecting ducts merging into a papillary duct. And the papillary duct, again, you'll have cuboidal cells. And when you have filtrate entering the papillary duct, it is officially known as urine and not filtrate, because filtration can occur above, and modifications can occur above this area. And so multiple papillary ducts will converge into a minor calyx. So now let's talk about the microanatomy of the kidney, where we talk about the specialized blood vessels. And so here's a diagram of how blood flows from the aorta into the kidney, and the capillaries that it will have to go through, and how it's going to remove the blood from these capillaries and return it back to the main blood supply. So the renal artery, as we know, is going to supply the kidney, and the blood vessels that are going to be associated with this renal artery are going to be a series of arteries. But then when you get to the kidney itself and the tubules, you have specific arterioles that are going to be associated with the tubules. So these arterioles are the afferent and efferent arterioles, where the afferent brings blood to the glomerulus, and the efferent takes blood away from the glomerulus. And then you have capillary systems, which are three. You have the glomerular capillaries, which are going to be involved with filtration. And then you have the peritubular capillaries and the vasa recta, which are going to be important for reabsorption and secretion. Of course, the glomerulus is going to be located in the glomerular capsule, whereas the peritubular capillaries are associated with the proximal and the distal tubules. The vasa recta is associated with the loop of Henle. So let's take a look at this process. So of course, you have left and right renal arteries, which are going to be a branch of the abdominal aorta. And the kidneys are going to receive about 1/4 of the total cardiac output. So if you remember, cardiac output is about 5.7, I think, liters of blood. So you're going to get 1/4 of it, which is about 1.2 liters of blood per minute. And so from the renal arteries, it's going to branch into smaller vessels through the renal sinus and on its way to the renal columns and then to the renal cortex. So if you trace the pathway, it goes renal artery, segmental artery, interlobar arteries, arcuate arteries, and then cortical radiate arteries, which is also known as interlobular arteries. So then from the cortical radiate arteries, you're going to feed directly into the afferent arterioles, and then the afferent arterioles are going to feed directly into the glomerulus. So that's the pathway that you are tracing. But if you look at the picture, here's your renal artery. You have multiple segmentals, right? And then these segmentals are going to go up into this column, which is the interlobar arteries. And then the arcuate arteries are actually going to border the cortex and the medulla. And then if you take a closer look, so here's your arcuate artery, the cortical radiate artery is going to radiate into the cortex. So that's why it's called a cortical radiate artery, because it's radiating into the cortical region of the kidney. And of course, the afferent arterioles. So kidneys contain, again, an unusual capillary bed where you have an afferent arteriole feeding into a capillary, and it's going to be drained by an efferent arteriole. Whereas we know the normal way a capillary is drained, fed and drained, will be arteriole into the capillary bed, and then you have a post-capillary venule. So the kidney is specialized where it does not have that. So again, each interlobular or cortical radiate artery is going to lead into an afferent arteriole, which is going to feed a bowl-shaped capillary bed called the glomerulus. And the glomerulus and its capillaries are a part of the renal corpuscle. And of course, the renal corpuscle is going to be where you have filtration occur. And this capillary is going to drain into an efferent arteriole. And this efferent arteriole is going to feed into the second capillary beds, which would be the peritubular capillaries, which is a network of plexus that's going to surround the distal and proximal tubules. And this efferent arteriole will also surround the vasa recta, which will again be in the medullary area of the kidney. And again, if you trace it, afferent arteriole, glomerulus, efferent arteriole, peritubular capillary, and the vasa recta. And of course, from that is going to exit into the venous supply. So the peritubular capillaries and the vasa recta can actually, well, let's talk about it real briefly. These are going to eventually lead into a larger venule that's going to go to the cortical radiate vein or the arcuate artery. And so we don't really talk about the venule, but know that there is a venule that is only probably but so big that's going to actually lead into the veins, okay? So the cortical radiate arteries are going to mainly receive blood from the peritubular capillaries, but it can also receive blood from the vasa recta. But the vasa recta can also drain directly into the arcuate arteries. And so from those peritubular capillaries and vasa recta, in general, will go cortical radiate arteries, arcuate veins, interlobar veins, and renal veins, okay? So cortical radiate veins are going to be the vessels that are, again, just to keep the name similar, is going to radiate or primarily be in the cortex, and it's going to radiate downward to the arcuate vein. And from the arcuate vein is also going to border the cortex and the medulla, is going to go into these interlobar veins. And the interlobar veins are going to all combine to form the renal vein. Okay? Notice that there is an absence of a segmental artery. So the purpose of a segmental artery is actually to displace all of that pressure that is coming from the renal artery. And of course, this renal vein is going to drain directly into the inferior vena cava. So remember that the kidneys contain two structurally and functionally distinct regions of, or distinct nephrons, not regions, but nephrons. You have the cortical and the juxtamedullary nephron, and of course, this is going to have distinct nephron loops, and they're going to have very unique capillaries associated with these nephron loops. So if you look at the cortical nephron, again, this makes up about 80% of the nephrons in the kidneys, and it's going to primarily be high up in the renal cortex. Of course, you have your renal corpuscle, which is going to be associated with a short nephron loop that is barely, or if at all, will enter into the the renal medulla. And this is mainly going to have a paratubular capillary that is going to surround not only the proximal and distal convoluted tubules, but is also going to surround the nephron loops because it's in mainly the cortical regions. And these paratubular capillaries of the cortical nephrons are going to supply blood to the loops of the cortical nephrons indirectly by exchanging materials through the interstitial fluid. Then you have the juxtamedullary nephron, which is less common than the cortical nephrons. And of course, you have your renal corpuscle, which is found near the cortex and medulla, and they're going to have these very long nephron loops that's going to travel deep within the renal medulla. Of course, the cortical portion of the nephron is going to be surrounded by these paratubular capillary branches. And of course, and then you have the nephron loops, which is going to be surrounded by the vasa recta. And this is going to arise also, both of them are going to arise from the afferent arteriole like discussed in the previous slide. And this is a unique capillary structure that allows for the arrangement of the juxtamedullary nephron to control volume and concentration of the urine. So that's the whole purpose of this vasa recta. Okay. And so now we're going to talk about the juxtaglomerular apparatus. And so you have the efferent and afferent arteriole, and it's going to come in close contact with the distal convoluted tubule. You might read that it comes in contact with the ascending limb of the nephron loop, but that's probably going to depend on where this nephron is located, but it's safe to say it's more so associated with the distal convoluted tubule. So with this juxtaglomerular apparatus, you're going to have three different types of cells. The first type of cell you'll have is the macular denser cells, which are closely packed cells close to the distal limb or the ascending limb, the distal tubule or the ascending limb. And this is going to contain chemoreceptors that sense sodium chloride content in the filtrate, okay? Then you have the granular cells or the juxta glomerular cells, and these are enlarged, smooth muscle cells of the arterioles. So they're found in the afferent and efferent arterioles, and they're going to act as a mechanoreceptor to sense blood pressure in mainly the afferent arterioles. And these are going to be the cells that are actually going to produce renin. Lastly, this orange group of cells right here that's not labeled are the extraglomerular mesangial cells that are located between the arterioles and the tubular cells, and they have interconnected gap junctions, and they're going to allow for the signals to be passed between these juxtaglomerular cells and the macular denser cells. So these three cells are what makes up the jugular glomerular apparatus. So nephrolithitis is the formation of kidney stones or renal calculi. And of course, renal calculi are crystalline structures that are going to be mainly calcium oxalate salts. But you can also have these form via sodium ions, hydrogen ions, and of course, uric acid. And of course, when these things are present in large amounts, this is called supersaturation. So this is how those calculi are formed. And so what happens with these crystals, they usually form in the nephron loops and also the distal tubules, because this is where you start to see the main concentration of the filtrate happen, and also the collecting system. Of course, most of these crystals do pass, but they can adhere to the epithelium of these tubules. And so these are called seeding crystals. And when the seeding crystals get large and break off, then they can start to disrupt the calyxes. And as you can see here, between the renal pelvis and the ureter. And of course, they can be very painful. The factors that cause this to occur will be dehydration, if you have diet that's high in fat, animal proteins, and salt, and also obesity. And of course, you'll feel pain, which is called renal colic, which radiates from the lumbar region to the pubic region, which makes sense because the lumbar region is where you find the ureter and parts of the kidney, and of course, you'll feel it where the bladder is located. Of course, you'll also see blood in the urine. A person will sweat, they'll be nauseous, and they'll vomit. And of course, you diagnose this with a computered tomography, which is CT scan, and you can also use an IVP to visualize the stone. So the organs of the urinary tract, which is going to be important for transport, storage, and elimination of the urine, are going to be the ureters, which you see right here. And the ureters are going to be slender tubes that convey or transport urine from the kidneys to the bladder. And they begin about the L2 vertebrae. So this is L1, so L2 vertebrae. And these are also going to be retroperitoneal. And they're going to enter into the bladder at the base. When you look at the ureter, it's going to be composed of a transitional epithelium. And so the transitional epithelium is going to be important because this is going to allow for the ureter to expand and change in shape. Of course, you have smooth muscle, which is going to make up the muscularis, and it's going to help with the propulsion of urine towards the bladder. Gravity alone is not going to be enough in order to move urine towards the bladder. So you're going to have peristaltic waves that's going to move or propel the urine towards the bladder. And the rate of peristalsis will adjust for to the rate of urine formation. And of course, you're going to have sympathetic and parasympathetic innervation of these muscles. And then the outer portion is going to be adventitia, which is going to be a fibrous connective tissue. And so, as I said, the ureter is going to enter in at the base of the bladder. And one of the things that's going to control the urine entering the bladder is that as the bladder fills up with urine, you'll have an increase in pressure at this distal end, and it's going to compress on these openings, okay? And so the urinary bladder is a muscular sac that's going to act as a temporary storage unit for the urine. Is also retroperitoneal and is going to sit on the pelvic floor posterior to the pubic symphysis. Of course, in males, it's going to be surrounded by the prostate. And so in females, there is no prostate. So here is the urinary bladder of a female. Here is the urinary bladder of the male. Of course, when you look at the female's bladder is going to be anterior to the vagina and the uterus. So here's the vagina, here's the uterus. So this is, I was pointing to the wrong thing at first. So the vagina and uterus is anterior to that. When you look at the urinary bladder, you have the openings for the urethra. No, sorry, the opening for the urethra and the ureter is going to form the structure called the trigon, which is a smooth triangular structure that is outlined by the opening of these things I just mentioned. And so you see, if you have a urinary tract infection, it will persist in this area. The mucosa of this organ is going to be a transitional epithelium. You have the muscular layer, which is going to be composed of this detorosor muscle, which is going to contain 3 layers of smooth muscle, an inner and outer layer, and another, the inner and outer layer are going to be longitudinal layers, and you're going to have a middle layer that's going to be a circular layer. You also have a fibrous adventitia, which is going to be on the superior surface of the bladder. The bladder is going to also be supported by the lateral umbilical ligaments. So here's one right here and another one right here, and the middle umbilical ligament. Urine storage capacity of the bladder, of course, it collapses when empty. You'll see rugae inside, and when it expands and rises superiorly, and it will fill significantly, and you'll have internal pressure that will, of course, stimulate the urination reflex. A moderately full bladder is about 5 inches, and it can hold about 500 on the lowest end, up to 1 liter of urine. And so it can burst if you overdistend it. So that's a key thing about the bladder, okay? The urethra is a muscular tube. So here's the urethra, that is going to drain the bladder, and it's going to be lined with epithelium. Mostly it's going to have pseudo-stratified columnar epithelium, except you'll have a transitional epithelium near the bladder, and then you'll have a stratified squamous epithelium near the external urethral orifices. And you're going to have sphincters, which you don't see here. You're going to have the internal sphincter. Well, you see it, but you don't see it as well as you saw in the previous picture. The internal sphincter, which is involuntary smooth muscle. between the bladder and the urethral junction, and it's going to contract to open. And then you have an external sphincter, which is going to be voluntary and is going to surround the urethra, where it's going to pass to the outer environment. Okay. In the males, the urethra is longer, and the urethra in the males are going to be divided into three regions. You have the prostatic urethra, you have the membranous urethra, and then you have the spongy urethra. And in females, the urethra is significantly shorter, and is going to be bound to the anterior wall of vagina. And so the difference between the length of the urethra of the male versus the female, it makes females more susceptible to bacterial infection. So females have to make sure they're mindful of how they wipe after they urinate or even defecate, because if you expose any bacteria that comes from the gastrointestinal tract, it will cause an infection. Okay. And when you look at the female, the external urethral opening is going to be located between the vaginal opening and the clitoris. So it's posterior to the clitoris, and it's anterior to the vaginal opening. So the development of the urinary system. So you will start to see the mesonephros, which is right here, develop from what is known as ureteric bud, and this happens around 5th week of pregnancy. And of course, this will come from the mesoderm of the urogenital ridge, and of course, this is going to end up forming the nephrons. And of course, the distal end of this ureteric bud will start to form the renal pelvises, the calyxes, and the collecting ducts. You do start to see the uretic duct. So you have the ureteral bud. The uretic duct will start to form around 6 weeks. And of course, this is going to become the ureters. And so as you can see, the kidneys, along with the mesonephros, which is going to be the kidneys, along with the uretic ducts, will start to move superiorly in the fetus. So it begins close to the cloaca, and then by 8 weeks, it will be close to position. All right. And the kidneys will excrete urine into the amniotic fluid about 3 months of gestation. And then you'll start to see the cloacal subdivisions into the rectum, the anal canal, and then you'll have a urogenital sinus that will also start to appear. So here you have that, you start seeing that there. And then you see that you get the distinction later on. So as far as congenital abnormalities, there's going to be 3 that we're going to talk about, which will be horseshoe kidneys, where the 2 kidneys are fused across the midline, forming a U-shaped kidney. And this is usually an asymptomatic disorder, so there's going to be no problems associated with it. Or you can have a hypospadis, which is the urethral orifice is located on the ventral surface of the penis, and so you have to actually surgically correct that. You can also have polycystic kidney disease, where you have these fluid-filled cysts that's going to interfere with the function of the kidneys. This can be an autosomal dominant, very common and not severe, or it can be autosomal recessive, which is very severe. And of course, this may cause a defect in signaling proteins. And so when you look at the frequency of micturition is the process of urination in infants. This is due to a small bladder and less concentrated urine. So it's not as concentrated as you'll see in older people, because infants drink a lot of fluids. You'll start incontinence is normal for infants, so voluntary control of the urethral sphincter develop with the nervous system. E. coli accounts for 80% of the urinary tract infection, which will come from the digestive system, so improper wiping. Untreated childhood streptococcal infections can also cause long-term kidney damages. And of course, you can have sexually transmitted diseases that can also inflame the urinary tract. And this is going to be more common in males because the urinary tract and the reproductive tract of males are um, continuous with one another, whereas females, you have a separate opening for the urinary tract and the reproductive tract. Of course, most elderly people have abnormal kidney histology, and the kidneys will start to shrink and the nephrons will decrease in size and number. And so the tubule cells become less efficient. So at 80, you have glomerular filtration rate is going to be half of that of the young person. And so this can be associated with osteosclerosis of the renal artery. You can also have loss of bladder tone, which will cause frequent trips to the bathroom at night, and you'll see urinary incontinence, which can also develop more earlier in women who've had babies.